Hello, everyone. It's time to start our webinar. So welcome everyone to the monthly webinar of AFOMP. My name is Xianche Jing. I'm the chair of the Education and the Training Committee of the AFOMP. So this is actually the first webinar of 2021. I wish you all the happy new year and happy family. This webinar actually started last year, 2020, so in the celebration of our 20th anniversary, but this we're going to continue till this June this year, 2021. We hope for the last half year, we were able to meet more face-to-face, but now I hope you enjoy this webinar. So today's webinar, we have Dr. Diana as the speaker. She will give us a talk on the proton therapy and why and how. And our moderator today is Dr. Muhammad Amin Moslem. So here's a brief introduction of Dr. Amin. He's the president of Iranian Association of Medical Physics. He's also an associate professor of the Shiraz University of Medical Science, Iran. He's a head of the radiotherapy physical unit and the joint radiation protection officer. And lots of the head of founding members of ionization and non-ionization radiation protection research centers and many other positions. So he also published the 108 papers in peer-reviewed journals and the 180 conference presentations. He's also a member of educational board of 2 journals, past guest associate of the medical physics. This is the official journal of AAPM. So now I would like to pass the control to Dr. Muhammad Amin to moderate the whole webinar. So welcome, Dr. Amin.
Hello and good day to everyone. Can you hear me?
Yes, it's fine.
Okay. Good day to everybody. Thank you for inviting me. I would like to thank Professor Aaron and the team at AFOMP for inviting me and giving me this opportunity to moderate this meeting. I would like also to wish everyone a happy and healthy new year. And I hope that we will have a good
Sorry, Dr. Amin, we can't hear you.
Yeah.
You're muted.
Mute.
Okay, unmute it. You have to unmute. Amin. Okay.
Yes, I'm sorry. Somebody muted me from the other side. Well, we know that the physical dose distributions benefits of using protons are well demonstrated in a variety of body sites, and we know that for decades more and more centers have been opening and doing further and further things. We obviously we look forward to the presentation by Dr. Diana and Shamrailatpam. I thought just some points that might be of interest. I also thought I put them forward. Obviously, different technologies, many different technologies have been suggested and are being used. Also, the clinical evidence of benefits to patients. Of course, this is an important thing. For some countries where there's still a shortage of LINAC, normal LINAC technology, there is a debate and there's a question whether for such countries or regions in the world, doing proton therapy might be an issue, might be an option. And also going the other way around, stepping up, going to heavy iron. What are the indications for that? It is absolutely my pleasure to introduce our speaker today, who is, as I said, Dr. Dayananda Shamrailatpam. He is the head of the Department of Medical Physics at the Apollo Proton Cancer Center in Chennai, India. He has a rich CV, which I've selected a few items from. Over 24 years as a clinical medical physicist. He was involved in setting up the first proton therapy facility in India, a very relevant thing to us today. More than 18 years of teaching experience, 41 original articles, 150 abstracts, over 95 talks. He is recently become a member of the Education and Training Committee of the AFOMP, and I congratulate him on that. He's a member of the PTCOG, Particle Therapy Cooperative Group, another important issue to this talk. And he's in the past been the executive committee member of the Association of Medical Physicists of India, and also past editorial board member of the Journal of Cancer Research and Therapeutics. So it is my pleasure to introduce him and ask him to give his presentation. Dr. Dayananda, please. We look forward to your talk. Thank
you. You have to unmute, Dayanand. Please unmute. Not yet. You are still muted. So at the left corner down, there is a mute, unmute button.
It is not found.
Yeah, now it's okay.
Can you hear me right now?
Yeah, exactly. You can share your PPT and go ahead.
Is the PPT available on the screen?
No. When you're putting share screen, are you getting, nothing is coming up yet?
Is it okay?
No.
I have
Try once again, or then, okay, now it's okay. Yeah. Now okay. Now visible. Fantastic. Bye.
Sorry for the delay and the inconvenience. And my name is Dayananda, and thank you, Dr. Amin, for the nice introduction. And from India, and from on my own behalf, I think I wish all of you a very happy New Year and a very fruitful New Year to come. And of course, the topic is very short, proton therapy, why and how. The question is very short, but the answer is very extensive, very extensive. And I have been asked to cover many aspects of proton therapy, which is very expensive, and is going to be extremely difficult for me to cover all the points which has been highlighted by our moderator. But I'll try my best to cover most of the topics, but it is going to be just a snapshot of the topic. I'm not going to go into the detail of any kind of those discussions. So the proton therapy, why and how? Okay. So now I think all of us are aware about, and all of us have enough experience on the use of high energy X-ray radiation therapy And we also have witnessed a tremendous development in the high energy radiation therapy in the form of three-dimensional conformal radiation therapy to IMRT, BMED, radiosurgery, SBRT, and so on and so forth. And all this technology has been delivered using various softwares and the delivery equipment, which is shown in this particular slide. And common to all these delivery technique and the delivery equipment is the type of radiation. In all these techniques, we have been using the high energy X-rays, and which is an uncharged particle, and which is an electron form of electromagnetic wave, and it interacts with a medium primarily through Compton effect. The way how it loses energy and the deposit energy when it travels through a medium is like this. Like after the dematch, it just falls out exponentially. Okay, and since it falls out exponentially, then as exponential functions cannot be zero, if you try to use any form of any technique having this kind of radiation quality, then when you are treating this tumor, then you are bound to this radiation is bound to exit from the tumor. That means that if you have a critical organ just below the tumor, then you are bound to deliver that critical organ with the exit dose coming out of the tumor. So this is unavoidable in case of any form of radiation therapy using high energy X-rays. But in case of a charged particle, for instance, I think let me pick up the proton because this is the simplest charged particles which we can talk about. And the proton, as you know, is the nucleus of a hydrogen atom having a unit mass and having a unit positive charge and a mass of around 1.6 into 10⁻⁻27 kilogram. And it interacts with a medium primarily through three processes: the inelastic column scattering, and inelastic column scattering is responsible, or it influences the penumbra of the radiation beam. And the second one is the non-elastic nuclear interactions, which has got relevance in the shielding thickness calculation. And the third one is the inelastic column interaction. When proton interact with the medium, it loses its energy through inelastic column interactions. And as you can see over there, the rate of energy loss per unit track length when it enters in the medium is inversely proportional to the velocity square of the proton. So as the proton enters inside the medium, it started losing the energy, and almost at the end of the range, or when the velocity is about to become zero, then it deposits all of its energy at that particular location, and that leads to the formations of a very high dose near the end of the range, which we call it the break peak. So the formation of the break peak from a charged particle or from proton beam is the rationale for using proton as a for the treatment of cancer. So as you can see over here, this is the depth dose characteristic from proton from X-rays. Okay, and so if you are treating the same tumor using X-rays, then you deliver a relatively higher entrance dose as well as you also deliver dose to the critical organ from the exit dose. But in case of proton, since the proton has got a finite range, and we can stop them wherever we want, and we can deposit all of our dose only to the tumor while completely sparing the normal tissue. So this physical characteristic of the proton beam is the primary rationale for using proton for the treatment of cancer. And another rationale for the use of proton beam is a relatively or slightly higher RBE of 1.1. I think we will come into the detail of this RBE in the later part. So in short, the proton beam has got a distinct physical advantage in terms of its practical characteristic, and it also has got a 10% increment in the RBE. So these are the two rationale for the use of proton for the treatment of cancer. And the use of this practical characteristic for the treatment of deep-seated cancer was first proposed by a physicist, Robert Wilson, in his seminal publications in radiology in 1947. So in these papers, he not only have proposed the use of Brackwig to treat tumor, he also have proposed the use of a device, a hardware or a rotating absorber. I think I'm getting a lots of noises. Is it from me or is it from some other?
Somebody's mobile or somebody's phone is ringing, I think. Please, the participant, put off your mic.
Okay. So in this paper, Robert Wilson has also proposed the use of a rotating wheel or rotating absorber to spread out the Bragg-Peak, because the Bragg-Peak, what we saw from a monoenergetic proton beam, is very narrow. The width of this Bragg-Peak is very narrow, whereas the extent of the tumor is quite large, what we see in the clinics. So you cannot cover this particular tumor by a single proton energy. So you have to broaden out the Bragg-Peak of this proton beam by superimposing the Bragg-Peak from multiple proton energies. And Wilson has proposed a rotating absorber wheel to split out this particular Bragg-Peak in order to encompass the extent of the tumor in the direction of the beam. So this is what we call a split out Bragg-Peak. And what will be the energy of the proton beam to treat this particular tumor, and how many proton beams are required to treat this tumor depends on the depth of the tumor and as well as the extent of the tumor along the direction of the beam. So even in this diagram also, you can see very clearly that I think you are treating the entire tumor, whereas you are delivering no dose to the organ at risk. And although the proposal came from the Harvard University where Robert Wilson was working, but the first patient was treated with proton beam in Berkeley universities or Berkeley laboratories in 1954, and that was a case of pituitary adenoma, pituitary for hormone suppression. And in this treatment, they even didn't use the Bragg-Peak. Rather, they used the plateau region of the Bragg-Peak, and they used a cross-firing technique to irradiate the pituitary gland for hormone suppression. And during those days, of course, the image guidance started along with the proton beam therapy, and they have used the kilovoltage X-rays beam to localize the target prior to the irradiation. But compared to X-ray radiation therapy, the progress of proton radiation therapy has been very, very slow. And till I think the first hospital-based proton therapy facility was set up at Loma Linda universities in 1990. So you can see from this graph that the number of facilities and the number of patients treated with proton radiation therapy was very, very minimal. But after 1990, you can see an exponential increase in the number of proton therapy facilities as well as the number of patients treated with the proton therapy facilities. And this could be because I think in the earlier days, prior to 1990, most of the proton therapy centers were affiliated directly or indirectly with the nuclear research laboratory or the physics research laboratory. And all the patients were treated in a very strictly controlled clinical protocols or clinical trials. And but after 1990, when the hospital-based proton therapy was set up in Loma Linda, then you can increase you can see the number in the increase the proton therapy facilities. But even after that also, still we are treating approximately less than 20% of the whole radiation therapy patients treated with X-ray radiation therapy. This less in number is primarily because of the cost-benefit ratio, because always time, I think there is a heated debate, even in the scientific meeting, that we have to justify the cost-benefit ratio of this particular modality, because we know that the proton therapy is much more expensive compared to the X-ray radiation therapy. So I think you can see all those arguments and the debates in this literature, I think, which has been reported in such a high impact factor journal. But despite of all this scientific debate on the cost benefit ratio, Then there has been a tremendous development in the proton therapy, as you can see from the number of facilities which are under operations and the number of publications in the last 2 years. So you can see over here, there is an exponential increase in the number of publications in peer-reviewed journal, and the number of facilities across the world has increased significantly. Now we have around 109 proton therapy facilities in operation, 37 under construction, 29 in planning. And this increase in the proton therapy facilities are primarily because of the latest development in the technology, or the technological development in the form of the active scanning technique as well as image guidance, and of course, this is the cost-effective solution, which is very, very important. So industry also realized that one of the reasons why people are not able to go with the proton therapy facilities was the cost. So they also worked to reduce the cost, and now they have come out with a cost-effective solution in the form of single room solution. So because of all these factors, the number of proton installations and the number of proton installations has increased significantly in the last 2 decades. Then what do you require to start a proton therapy facilities? Okay, and so this is the architectures of a proton therapy facilities. The heart of the proton therapy facilities is the accelerator, the charge particle accelerator, or the proton accelerator, which could be cyclotron or synchrotron. And you have to have a energy selection systems depending on whether you are, suppose if you are using a cyclotron based system, then you have to have an energy selection system. And you also require a beam transport system to transfer the beam from the accelerator to the treatment delivery room. And finally, you need a beam delivery system. And so this is all of these are termed as the beam management system. And beside that, you also need to have a patient positioning systems, just like the linear accelerator or the photon beam or the X-ray based radiation therapy. You need to have a patient positioning systems, and you also need to have a positioning system for the proton beam. And finally, I think this is a very complex architecture. So you have to ensure the safety of the proton delivery. So for that, you have to have a very robust and the therapy safety system. And of course, I think everything will be controlled through the therapy control system software. So the first, the cyclotron, I think, was patented by Lawrence in 1932. And this is the prototype cyclotron which we patented in 1932. And that, I think, is a very small cyclotron which can accelerate the proton up to 80 keV only. But the commercial cyclotron, I think the first commercial cyclotron was from IBA and Sumitomo, which was launched in around 1996. And it was a normal conducting isochronous cyclotron with the model name called C230. And still, I think in majority of the proton therapy center, this particular cyclotron is used because this is considered to be one of the roughest and one of the most stable cyclotron available in the market. And this has got a physical diameter of 4.3 meters with a weight of around 220 tons. You have to have a azimutally varying magnetic field, and the peak magnetic field strength associated with such kind of cyclotron is around 2.2 Tesla. And it produces a proton energy of 230 MeV. And of course, I think after that, there has been a significant development in the proton therapy technologies. So from this time onward, from this time onwards, people started working on the reduction of the size of the cyclotron as well as the weight, because the size and the weight are directly proportional. This size is required to accelerate the proton up to an energy of around 230 MeV, which corresponds to approximately 32 grams per centimeter square range. Okay, so so we have to reduce the size of the cyclotron as well as the weight of the cyclotron. So this is able to achieve with the help of a superconducting technology. So the first superconductor conducting cyclotron was introduced by SL, which is taken over by Barian now in 2005. And this is also a isochronous cyclotron, but it is a superconducting cyclotron. And with this technology, you can see the size is reduced to 3.1 meter with a corresponding reduction in the weight to 90 ton. And the peak magnetic field strength associated with this isochronous cyclotron is 4 Tesla, and it can produce a fixed proton energy of 230 MeV. The next development came from IBA again. I think they have introduced this S2C2 cyclotron, but in this case it is a synchrocyclotron, not an isochronous cyclotron. This was introduced in 2018, and you can see over here the size is still reduced to 2.5 meter, and the weight is just 50 tons compared to, so for example, 90 tons from barium and 220 tons from, again, the IBA isochronous cyclotron. And the peak magnetic field strength associated with this cyclotron is around 6.6 Tesla, and this cyclotron can produce a maximum proton energy of 230 MeV. And the smallest cyclotron available in the market till today is from Mavion, which was introduced in 2013. And this is also a superconducting synchrocyclotron, and having a diameter of just 1.8 meter. This is the smallest, and it has weight only 20 tons, and it can accelerate proton up to 250 MeV maximum energy. So this is the smallest cyclotron available in the market, and as well as this is the lightest cyclotron available in the market. That is also the reason why Mavion mounted this cyclotron in the gantry itself. And this is the only system available in the market who doesn't use a energy selection systems, which we come in the later part. So this is the development in the cyclotron technology over the period of time, and this is what it is available in the market. Very recently in 2019, IBA have introduced another cyclotron, because all these cyclotrons are designed to accelerate light ions, but that is proton. Okay, they are not meant for accelerating or heavy charge particle like carbon. But in 2019, IBA have come up with another cyclotron, which is an isochronous cyclotron again, to accelerate light ion as well as heavy ions. Okay, so they call it C400. It is isochronous cyclotron, and of course the size is quite big. It is not a superconducting technology. It's a superconducting technology, but still the size is quite big, 6.6 meter with 700 tons, because they have to accelerate the other charged particles like carbon ion also. So the maximum energy which can be accelerated with this kind of accelerator is up to 250 MeV, whereas it can accelerate 400 MeV per nucleon in case of carbon ion. As I said, I think most of the cyclotron technologies are very good to accelerate light ions, especially the proton. But if you want to accelerate heavy charged particle like carbon and other heliums and all, then the preferable option is a synchrotron. Of course, the operational principles of the cyclotrons and the syncrotrons are pretty similar, but the difference is instead of confining the big magnet in a single unit, they distributed the magnet in smaller unit like this. Okay, so this is the first synchrotron, which was built by Fermi Lab and which is installed in Loma Linda for the treatment of cancer. And unlike cyclotron, in synchrotron, you need a energy, or you need a linear accelerator to inject the charged particle for the acceleration. So this injector is in the form of a linear accelerator. So these linear accelerators will accelerate the energy of the charged particle to an initial energy of approximately 2 to 7 MeV, depending upon the type of the charged particle. And once it is accelerated up to 2 to 7 MeV by using this linear accelerator, which is called as an injector. So this charge particle will be accelerated in this circular fashions by using the various magnet distributed along this circle. And by this time the particle completes a rotation, then it is going to gain its energy. So you have to accelerate the charge particle multiple times to get the energy what you require. And this time when it completes a particular revolutions, then you also have to change the magnetic field strength to keep the charge particle rotating in the same radius. Okay, and the two commercially available cyclotrons are from Hitachi and the Mitsubishi. And there has been some development in the synchrotron technology also. So this is the old synchrotron technology wherein they use around 16 magnets. So you can see over here that the 16 magnets are distributed along this in this fashion. Okay, and 6 of dipole magnet and 10 of quadrupole magnet, and they can accelerate proton energies of up to 250 MeV. And you can see over here the diameter of this assembly is around 7.8 meters, excluding the injector. Okay, but in the new design, they have come up with a compact design, and in this compact design, they have reduced the number of magnets to just 8 with 4 dipole and 4 quadrupole magnet, and they are able to accelerate up to 220 MeV proton. And you can see over here that the diameter of this assembly has reduced to 4.1 meter compared to 7.8 meters of the old design. So this is a development in the synchrotron technology. And of course, the two vendors which use synchrotron technology is Hitachi and the Toshiba. So this table shows you the comparisons of the different types of accelerator, the synchrotron, the isochronous cyclotron, and the synchrocyclotron. And as we have already discussed, the size and the weight is one parameters which we consider very seriously for all these accelerators. So you can see the synchrocyclotron has the minimum dimension compared to cyclotron, isochronous cyclotron and synchrocyclotron. And of course, I think isochronous cyclotron, the beam is continuous, whereas in synchrocyclotron, the beam is in the form of a pulse. But in case of cyclotron, compared to the cyclotron base, in synchrotron, you can extract beam energy of any kind what you want. Whatever the energy you want, you can directly extract it from the synchrotron. But in case of cyclotron-based system, the cyclotron always accelerates the proton or the particle energy up to the maximum energy, and you have to reduce the energy of that maximum energy based on your requirement outside the cyclotron. So which we will discuss in the later later part. And of course, to do that, I think this cyclotron-based system will be using a beam degrader to degrade the beam energy to the value which we require clinically. And this beam degrader leads to another challenge in terms of radiation protections. Because of this beam degrader, then the shielding thickness required for that particular facility is going to be more than that of a synchrotron-based system. And of course, I think these are some of the technicalities, I think, which matters in the delivery of the radiation and the kind of technology, beam delivery technology, what you are going to use. So for example, this technology, the synchrotron as well as isochronous cyclotrons are suitable for spot scanning technique, but whereas synchrocyclotrons are, I think they can do the spot scanning technique, but it requires relatively longer time. Okay, and of course, if you want to practice double scattering technique, I think of course all the accelerators, all types of accelerators are suitable for the double scattering technique. The second part is the energy selection system. So this is the typical combinations of a cyclotron-based proton therapy system. So we have a cyclotron over here. So what we do is we inject hydrogen gas inside the cyclotron. And once you strip out the electron from the hydrogen atom, then what is remaining is the proton. So that proton is accelerated inside this cyclotron up to the maximum energy, which can be 230 MeV in case of a IBA cyclotron, or 250 MeV in case of a barium and a Mavian cyclotron. And once it attains the maximum energy, then what we do is that we extract the proton out of this cyclotron. Okay, so now we have a maximum energy. So let's assume that in this case it is a 230 MeV proton. But in clinical practice, we have to treat our patients with different proton energies. Okay, so how do we get that particular that different proton energies? As I said, so this is the beam degrader. Okay, this is a rotating wheel beam absorber, which we call as a beam degrader. And this beam degrader is going to degrade the energy of up to 70 MeV. Okay. From 230 MeV, you can reduce it up to 70 MeV depending on your clinical requirement using this beam degrader. So this is done outside the cyclotron. In this area is called the energy selection system. So in this energy selection system, it is done by using this beam degrader. So while doing so, and lots of the scatter beams are produced transversely, and it generates a split of the beam energies. Okay, but what we require is a monoenergetic beam energies. Okay, and so this need to be collimated. So you need to remove out all those low energy wide angle scatter proton beams which are produced because of this degradation process, and that is done by using a collimation system in this energy selection system. And once the collimation is done, and once the low energy proton components are filtered out, then the monoenergetic proton beams are going to be transferred all the way through the treatment room through the beam transport systems, which I will show in the later part. Okay, so in this process, another problem is when this proton beam bombards with this kind of beam degrader, and when it interacts with the different medium, okay, along this path, it produces lots of secondary charge particles. Because in this case, as I have already mentioned, the primary interaction is a non-elastic nuclear interaction. Okay, so this proton is already interacting with the cyclotron, which is primarily made up of copper and iron, and it is interacting with the beam degrader, which is made up of copper again, and it is also going to interact with the collimating devices, which is made up of the tantalum, and it is going to interact with the divergent slit, which is made up of nickel. So when this proton beam interacts with all this medium, then because of this non-elastic nuclear interactions, it is going to produce lots of secondary charge and uncharged particle. The predominant of all this secondary radiation is the neutron and the gamma and the X-rays. And this neutron will have a very large energy spectrum ranging from thermal up to the maximum energy of proton, and the X-ray also will have the energy of up to 10 MeV. So that is also the reason why I said this kind of interactions are very important from the shielding design calculation. So we have to ensure that our shielding facilities are adequate enough from radiation protection point of view for the safety of the radiation professional as well as the patient or the general public. So we did a very extensive measurement of the neutron and the gamma radiation around the facilities using a VT2 neutron survey meter and the gamma survey meter. And these are the component of the ambient neutron and the photon or the X-ray dose at various locations around the cyclotron bulb, around the beam transport system, and around the gantry. And so we have documented these data in British Journal of Radiology in 2019. And so this is the beam transport system. Now you have the cyclotron, you have the energy selection system. So now I have a mono-energetic proton beam which is being selected over here, and that needs to be transferred all the way to the treatment delivery room using this beam transport system. And if you see towards the beam transport system, all these structures are bipole magnet, quadrupole magnet. Bipole magnets are basically used to deflect the beam to deviate the directions of the proton beam, whereas the quadrupole magnets are used to focus the beam continuously. And of course, along the line, you will have the profiler to do a online monitoring of the beam characteristic, and you will have the beam monitoring systems along the path. And so now this is the beam transport systems, and from there, with it comes to the treatment room. Okay, in the treatment room, you have this gantry, which will be allowing you to direct the beam from multiple angles. So this is what we call the beam positioning system. And this is your cows, and which is your patient positioning systems. So along with the image guidance system, the gantry, the cows, and the image guidance system is going to represent beam positioning systems and the patient positioning and the verification system. And this, what we call the nozzle, is the beam delivery system, which we will discuss in the later slides. And this is how how it looks like inside a treatment room. So this is the nozzle, which we are going to discuss in the later slides. And this is the robot, which is used to position your your patient. Okay. So now the fourth component is the beam delivery system. And the beam delivery system can be, I think, briefly, I think it can be of two types: the passive scattering technique. So in case of passive scattering technique, what it does is that, so this is the proton beam, the monoenergetic proton beam, what you get it from the cyclotron or synchrotron. Okay. And this is a very narrow beam, and what we require, so this is my patient. Okay, this is my patient, and this red one is my tumor, the tumor patient. And so you need to broaden this beam out to cover this target. Okay, so that is achieved by introducing the scatterer along the part of the beam. So first you introduce a scatterer over here, which will broaden the radiation field to approximately 5 by 5. And then you introduce another scatterer, which will further broaden the radiation field or the proton radiation field to approximately 25 by 25. Okay, and so you use a broad beam in the double scattering technique. Okay, and after that, to tailor or to get a conformal dose distribution laterally, then you have to create this kind of patient-specific and a field-specific beam aperture. Okay, and at the same time, unlike photon, in proton, we have another dimension which is called the longitudinal dimension. So as I said, so we cannot treat these patients with a single proton beam. We have to treat these patients with a multiple proton beam. That means, so this break peak need to be broadened out. Okay, and this break peak can be broadened out by using this range modulator. Okay, so this will broaden out the break peak of the proton beam. So that means multiple proton energies will be used to broaden out and to cover this tumor extent in the longitudinal direction. Okay, and to take into account of the tissue heterogeneities and the contour irregularities, you have to create another range compensator, which is also called a three-dimensional tissue compensator. So which is introduced along the part of the beam, just below the aperture, to get a conformal dose distributions towards the direction of the beam. So this way you can deliver a conformal dose distributions to the target. So one thing, some problem related to the double scattering or the passive scattering technique is, first of all, there is a spillage of those distributions towards the proximal end of the beam, which is completely unavoidable, but it can be reduced by using multiple beams from different directions. And at the same time, when we broaden the split out break peak, you also have to consider the decrease in the peak to plateau ratio. So for example, for a Preston break peak, the peak to plateau ratio is around 4.5:1. But when you broaden the beam, when you broaden the Preston break peak, then this value is bound to reduce. And in this example, it is to reduce to 2.1. This means that when you broaden the break peak, then you are bound to increase the entrance dose as well as the skin dose. Okay, though it is lesser than proton, but still it increases the entrance dose. And so this is a block diagram of one of the nozzle design used by Hitachi. So, and using this passive scattering technique, I think in the very beginning, people used to keep the patients using a robotic chair, and you have to have all these patient and the beam specific. You have to create, or you have in your laboratory or in your workshop, you have to create all these devices, and of course this cannot be reused. And so there is a big issues related to the radiation safety, related to logistic storage, then the manpower required to create all these, and also it produces a lots of neutron contamination. Okay, and all these difficulties, whatever all the shortcomings, what we have discussed over here, are rectified or are overcome in the active scanning technique. So in the active scanning technique, what you have is the proton beam, which is coming from the cyclotron or synchrotron, and you have removed all the components along the path of the beam. But what you retain over here is a pair of magnet. So one pair of magnet to scan the proton beam, because proton is a charged particle, so you can deflect it by applying a magnetic field. So by applying magnetic field strength in this magnet, you can deflect the beam in one direction. Say, for example, in this case, you can deflect it along the Y direction, and by using this, you can deflect it along the X direction. So by using this steering magnet, you can position the proton beam at different depth, and with that, I think you can treat the patient. And this is how it is done in I think I'll show you. So in this case, this is the same patient, the same tumor. So as I said, you can imagine that this tumor can be divided into multiple layers, and the further layer will be treated with a larger proton energy. And when it comes towards the proximal end, then the energy will gradually decrease, and the shallowest layer will be treated with the minimum energy. Okay, and of course, what is the energy? That depends upon the depth of the tumor and the extent of the tumor. So these are the different layers. So this will be treated with one energy. So now you start positioning the brake peak into this layer. So let's assume that this is for energy E1. Then once it is done, you come to the second layer. Then the energy will be changed to E2 and deposit the brake peak over there. So you keep on doing till you get a conformal, or you deliver the entire target. And you can see over here with the active scanning technique, the dose conformity is much better compared to a passive scattering technique. And the biggest advantage is you can avoid all those patient and the beam specific hardwares. And so there are many advantages. Of course, I think it is understood that the proximal conformity is better, and the entrance dose is less, then the integral dose is less. Then there is a reduction in the preparation time because you are not preparing all. So the start time for the patient treatment is going to be faster in a pencil beam scanning technique, because you are not going to prepare all those hardwares. And the time spent by the therapists are going to be much less, because they need not to sense all those hardware. And the adaptive radiation therapy, which is very important for proton, is going to be quite easy with the pencil beam scanning technique. And of course, there is no neutron contamination. And of course, this technique also has got certain limitations, and because they are very sensitive to the patient motion or the tumor motion. And of course, it is relatively slow compared to double scattering technique, but this is insignificant because the radiation on time is much less compared to the patient positioning and the verification time. And this is the system what we have in our center. So we have a Proteus Plus proton therapy system from IBA, wherein we have a C235 cyclotron, which supplies energy, or which supplies proton beam to two room of gantry, and the one is fixed beam room. And this is exclusively for pencil beam scanning technique, and the image guidance can be realized in the form of 2D to 3D, including the cone beam CT. And we do have a robot for 6-dimensional patient positioning correction. And we have a motion management system from Align RT in the form of surface-guided radiation therapy. And so, of course, I think we have characterized our system very extensively, and which has been reported in this Journal of Medical Physics. I think those who are interested in knowing more about the characterizations of the proton therapy systems can go through this literature. Like any other radiation therapy department, I think you have to have the multimodality imaging system. Like we have a 85 centimeter whiteboard CT scan, and we have a 3 Tesla MRI, and of course the digital PET CT. And the Ray Station, we use Ray Station as a treatment planning system, and it supports both analytical dose calculation algorithm as well as the Monte Carlo. And Mosaic is used as an oncology information system, and these are the different treatment roles. When it comes to the workflow followed in proton therapy are very much similar to that of photon radiation therapy, but the way how we look into each and every steps are very different. Because as you know, this proton or any kind of ion beams, they are very sensitive to the range uncertainties. And this is what we call the Bermuda Triangle of range uncertainties. And as you can see over here, so because of these uncertainties, so the way how we look into the different steps of the process are different. And I'm going to touch each and every point very briefly, and this is going to take a lot of time, but I'll try to touch each and every point. Okay, and especially for the pencil beam scanning technique or the active scanning technique, all the treatment planning is done using the intensity modulated proton therapy. So we can optimize the spot position, then the spot weight, and the energy layer separations by using 2 types of technique called the SFO, single fill optimization, or the multi-fill optimization. In case of single fill optimizations, what we do is that all those proton beam characteristics are optimized in such a way that each fill deliver a homogeneous dose to the target. And of course, if you combine all of them together, then you are going to deliver a highly homogeneous dose to the targets. You can see over here, fill number 1, fill number 2, fill number 3, each fill is delivering a homogeneous dose, and they combine together to get a homogeneous dose to the target. But in case of MFO, then each fill deliver a non-homogeneous dose to the target, but if you combine all of them together, then it delivers a homogeneous dose to the target. And in the recent past, there is a new approach called the robust optimization, wherein we introduce, instead of creating a PTV margin, which we generally do in case of photon radiation therapy and the double scattering technique, what we do is that we define the setup error and the possible range uncertainties during the optimization process. And we optimize in such a way that, or the algorithm optimized in such a way that it creates multiple scenarios, and they try to, all these scenarios try to converge to a solution wherein the resultant dose distribution is insensitive of the setup error and the range uncertainties. Okay, so this is what we call the robust optimization. And of course, the robust optimizations are always based on the CTV. And since the robust optimization is done, then we have to evaluate the plan, whether it is robust or not. So this is a typical example of 2 plans. So on this left-hand side, this plan, and on the right-hand side, I think the right-hand side is, by looking at those DVHs, we can say that this plan is more robust compared to this plan. Because the spread, the wider the spread of because these are the DVHs from the different scenarios. Okay, so the wider the spread of the DVHs from the multiple scenarios, lesser is the robustness. So in this case, the spread is very narrow. So this means that the plan is very, very robust in terms of the PTV coverage. Similarly, the spread is very narrow for this critical organ.
So that means that this plan is more robust compared to this plan in terms of the OIR dose. So this is how we evaluate the robustness of a treatment plan, which is not the usual case in case of photon radiation therapy or the X-ray radiation therapy. So there are many benefits of the proton beam therapy. And of course, the first one, what we see on day-to-day basis is the dosimetric benefit. And so we are able to reduce the dose to the OIR, and also we are able to reduce the integral dose. And this is going to have an implication in the form of reduction of toxicity profile. And since we can reduce the toxicity profile, then you can escalate the dose to, especially for those tumors which is considered to be radio resistant. And you also, I think, so radiation-induced carcinogenesis is considered to be one of the points which we discuss quite often in X-ray radiation therapy, and this has got more relevance, especially for the pathogenic tumor, pathogenic patient. But that can be reduced with the use of proton beam therapy because we are able to reduce the integral dose. And finally, all this dosimetric benefit has to be has to have a direct link with the clinical outcome. So the classical example to demonstrate the benefit, the dosimetric benefit of proton radiation therapy over photon is the irradiation of craniospinal axis. So in this case, you can see this is the plan created using proton beam, and this is the plan created with any advanced form of X-ray radiation therapy. Okay, and this is the difference. So with X-ray radiation therapy, so you are irradiating all the critical organs anterior to the target. So by using proton beam, so you can reduce the dose to almost 18 critical organs. Okay, and these are the various literatures which have demonstrated the dosimetric advantages of proton over photon to reduce the dose to all these critical organs. And using this DBH data, you can create a model, and these models predict the reduction in the toxicity profile, including the second radiation-induced carcinogenesis to all these critical organs. Like you can reduce the pneumonitis rate, you can reduce the cardiac failure, you can reduce the xerostomia. So these are the advantages of proton beam over photon radiation therapy. So I think in our centers also, we have treated quite a good number of craniospinal axis irradiation. And of course, I think the treatment approach for pediatric and the adult CSIs are different. And we also have developed a technique wherein we are able to deliver a very high dose or the therapeutic dose to the graviform plate, at the same time able to reduce the dose to the lens, besides reducing the dose to all the other critical organs anterior to the target. And as I said, I think since we can reduce the dose to the surrounding normal tissue, so we can escalate the dose. So this is one example wherein the dose escalation is required. So this is a case of sacral chronoma, which we treated in our center. So now I think we have escalated the dose up to 74 gray to this particular target without exiting the tolerance limit to all these critical organs like the rectum, then the bowel bag, then the bladder, and so we can escalate the dose to this kind of radio-resistant tumor. And even the radiation-induced carcinogenesis, it is not only the predictive model, one of the very good data published from the United States, I think, wherein they have compared the radiation-induced carcinogenesis treated with proton and the photon from two centers, where in a large number of patients, around 550 each, and they found that there is a significant reduction in the radiation-induced carcinogenesis treated with proton compared to photon. And of course, and again, one point is this is likely to be much better because during those days, the proton technology was still a double scattering technique. So with the pencil beam scanning technique, this is likely to improve further. And in terms of clinical benefit, of course, there are many data which are emerging and which are already there. And one of the data which I quoted over here is the increase in the survival of disease-free survival of skull-based chondrosarcoma. This has been reported from one of the highly experienced proton therapy center, the PSI in Switzerland and the Curie Institute in France. And in these publications, they have reported a 7-year disease-free survival of 93.1%, okay, and 7-year overall survival of 92.6%, which is really good, okay. So this is this is the advantage of proton therapy in terms of the clinical outcome. And another way is I did mention about the uncertainties associated with any kind of size particle therapy. So the dose calculation algorithm plays an important role in mitigating the dose calculations uncertainties. So this is the analytical dose calculation algorithm, and this is Monte Carlo algorithms. And what we found is that the analytical dose calculation algorithm in ray station has got a limitation, especially when we use a REN shifter, and the deviation was much high, and which goes up to approximately 8% at the cellular depth when we use a REN shifter. Okay, but whereas if you use Monte Carlo, then this deviation is much less. It's of the order of around 2%. Okay, compared to the measurement. And this has been validated, I think, in a heterogeneous medium also, and what has been documented in the literature, and what we also have found is that the Monte Carlo algorithm in ray station is quite accurate compared to the research version of Monte Carlo, like Gen4 and MC square, and so you can see over here the agreement is around 96%. Compared to all this research version of Monte Carlo. Okay, so this also shows the role of the dose calculation algorithm. You can see over here, this is a case which is a very highly heterogeneous medium. So this plan was created using analytical dose calculation algorithm. You see that the tumor seems to be covered very well by the prescription dose, but this is not what it is going to deliver on the patient, because if you just do the calculations using the Monte Carlo, you see that the target is not covered by the prescription isodose. But if you, this can be improved by using both Monte Carlo for the optimization as well as calculation. So this is how it is supposed to be, and this is what it is going to deliver on the patient if you do use the Monte Carlo for both calculations and optimization. And this is another example, I think, of adaptive planning. So, this is the case. So when we do the CT simulation for the planning, so this is the opening. There is an opening of the nasal cavities, and this is the dose distributions what we plan. So during the treatment, there is a filling of the nasal cavities. You see over here, and as a result of that, if you overlay the dose distributions to the new CT data set, then you see that the target is underdosed. So adaptive replanning is very common in proton radiation therapy, and because we cannot afford underdosing the target because of the change in the patient anatomy and the patient feeling.
Dr. Dyanand, can I ask you, in the interest of the time, could I ask you to sum up in 5 minutes, possibly? Please?
Okay.
Thank you.
So another advantage of proton radiation therapy is in the case of re-irradiation. So this is a case of re-irradiations wherein we have to deliver 60 gray to the tumor, and at the same time we have to restrict the dose to these optic nerves by just 9 gray. So we ran a competitive plan between TOMO and the protons, and what we observed is in TOMO, if we want to restrict the dose to these optic nerves, we were underdosing the target significantly. You can see over here, the target is underdosed significantly, but with proton ion PT, then we are able to deliver the therapeutic dose to the target while protecting the dose to the critical organ. So this is, you see over here, we are able to restrict the dose to the optic nerves to 9 gray, or at the same time deliver the therapeutic dose to the tumor, which is not the case in case of photon radiation therapy. So another challenge in proton radiation therapy is the presence of metals, because any kind of metals can easily perturb the range, and this was documented even in 1986. So the presence of this kind of in homogeneous medium can easily perturb the distal fallout up to even 32 millimeter, okay, 3.2 centimeter. So we need to know how to mitigate this kind of uncertainties. And this is a very, I think, some sort of provoking data. I think so. The PSI data shows that I think there is a significant reduction in the overall survival rate in those patients who are treated for the chordoma with the metal implant or the surgical implant. So you can see over here in those patients where there was no surgical implant, the 5-year survival rate was 100%. But in those patients where the surgical implant was there, then the survival rate has dropped to 30%. So this was a very, I think, so alarming situation. And so they have concluded that I think the proton therapy is very safe, especially when you have situations wherein those surgical implants are not there, but they have given a caution about the presence of metal implant. Later on, this has led to a different studies wherein they have retrospectively investigated the impact of the implant in an in vivo dosimetry system, and they have come out with different strategies how to you mitigate this kind of dose error through this experiment. And they have concluded that whatever the poor survival rate which was reported in the earlier publications was not because of the metal implant, but it was something to do with the disease itself. So we also have adopted most of the mitigation strategies available in the literature, and above that we also have our own innovative approach, and we use the MBCT to reconstruct the metal implant very accurately. And so once you are able to reconstruct the metal implant very accurately, and once you are able to identify the artifact thrown out by the implant appropriately, and if you adopt all the mitigation strategies, then I think you will be able to deliver the plant dose to the patient. So this is our mitigation strategies which we have come out. And of course, as I said, I think pencil beam scanning techniques are very sensitive to the organ motion. And we know the organ motion, I think even in photon also. And this is also one of the biggest challenges, even in photon also. But compared to photon, an additional, I think, area where we have to be very cautious about the organ motion, especially when we use pencil beam scanning technique, is the interplay effect. Okay, so if you are using a double scattering technique, then I think the organ motions are not very sensitive, because this publication shows that the dose error is of the order of around 3% if you are using a double scattering technique. But if you use a pencil beam scanning technique, because of this interplay effect, this can go up to around 23% deviation. Okay, and of course, since you are treating them in a high fractionated manner, when you complete the 25 fraction, then this error may be reduced up to 8.7%. So we have to know how to mitigate this kind of interplay effect in proton radiation therapy. And of course, there are consensus guidelines which describes you how to mitigate these uncertainties. And for that, I think so what we have to do, I think I cannot play this video now. And so you have to do a very extensive the phantom verifications before you implement such kind of technique in your clinic. And this also can show that. So if you are considering the tumor as a stationary tumor, so you deliver, this is the dose what you deliver. And of course, once the tumor is in motion, then you are delivering a very, very heterogeneous dose to the tumor. And in some area, you are completely underdosing, and in some area, you are completely overdosing. And at the same time, the OR dose are also increased. But this can be mitigated by using say, for example, the scanning technique. So if you scan the proton beam multiple times, so for example, in this case, 6 times, then the dose distribution to the target is improved. I have been asked to touch a little bit about the other charged particle. So of course, since this is the depth dose characteristic from multiple charged particle, and so let me concentrate on proton and the carbon, which are very commonly used for the cancer treatment. So if you compare this to the Preston break peak, then what you see is that of course the carbon has got a very high peak to plateau ratio. Okay, at the same time, it has got a very sharp penumbra. You can see over here. This is the penumbra characteristic of protons and the other charged particle. And so proton has got the highest penumbra compared to the other charged particle, and the carbon has got a very least penumbra. So the carbon has got a physical advantage in terms of a sharper penumbra and higher peak to plateau ratio. But at the same time, the carbon has got a fragmented tail. See over here. So this is the fragmented tail from the carbon ions. And though the dose contribution from these fragmented tails are relatively less, but these fragmented tails are because of the higher LET radiations, which will have a bigger radiobiological effective dose. Okay. So this is not a component of the primary dose. This is elongated from the primary component. So we have to be extremely careful about this fragmented tail, and this fragmented tail may go up to 15 centimeters depending upon the energy of the carbon ion or energy of the beam. And as it has got higher RBE, so this is we have to handle it very accurately. Otherwise, this may lead to a unwanted exposure to the critical organ. And that is also one of the reasons why the carbon ion has been restricted or restricted for the pediatric patients. And of course, it has got larger uncertainties in the RBE, though proton also have got a RBE variation from 0.7 to 1.5. Globally, we are taking it as a 1.1, but the carbon has a much higher RBE ranging from 2 to 5. Okay, so we have to have a treatment planning systems which takes into account of this RBE, and this RBE is, I think, is a function of many parameters, and there is a lot of uncertainties in the RBE, and I think another area is, again, I think the new development in any kind of radiation therapy is the LET, because we know that there are uncertainties associated with any kind of charged particle. So now this is the dose distribution from a physical dose, and this is the dose distribution from a LET-based planning. And then you can see over here, so in the physical dose distributions looks perfectly all right when we evaluate it, but when you evaluate it to LET, then you see that much higher LETs are deposited to this particular area where it is affecting with the critical organ. So this can be improved by incorporating the LET-based optimization, which is still under research. And recently, I think registration has launched this. So I think they have come out with this product, but it is still mostly, I think, in the research model, not in the clinical application.
Dayanand,
can I finish? Yeah, I can finish then.
Because we have to take questions also.
Right. And then let me finish over here then. And I think at least let me, please allow me to share this picture. So this is the great team I have over here. So they are all my physics colleagues. And can you see my slides now?
Yeah.
Okay. So I think this is my team. So we have a site-specific and the job-specific physicists over here. So some of us are doing only the machine-related activities, like some of, I think, like my colleagues here over here, Manikandan and Ganapati, they take care of the machine, the quality assurance, the patient-specific quality assurance. Other colleague of mine, like Dr. Naufal and Karthik, Rajesh, they take care of the site-specific treatment planning. And my other colleagues take care of, like the Mayur and the Shriyakan, they take care of the photon as well as the oncology information system. And this is the complete team of clinical. This is our director, medical director, Dr. Jalali, and all the consultants around. So this is the team which we work over here. Thank you very much for your kind attention.
Thank you very much, Dr. Dayanand Sharma. I enjoyed your talk, very, very interesting and very informative. Thank you very much. An interesting talk, and therefore there were quite a few questions put forward. You can hear me, right?
Yeah.
Yes, okay, great. If I may put them to you, there were a couple of questions regarding conversion from X-ray dose to proton dose. Are you going from photons to protons? You mentioned the RBE of 1.1 for protons. Anything you would like to add to that, please?
Okay. And of course, I think when we measure the BIM data for the commissioning of the treatment planning system, what we measure is all physical dose. Okay. And so depending on how you want to practice, then I think we can handle this RBE 1.1 in two ways. One way, or the simplest way, is to continue the dose prescription strategies what we have followed for the photon radiation therapy. Like, say, for example, let's assume that we have been prescribing 54 gray to a particular tumor in photon radiation therapy. Okay, so if we want to follow the same convention, so what we do is that we introduce this 1.1 RBE in our treatment planning system. Okay, so the radiation oncologists need not to change their dose prescription strategies or the convention like what they have been from their photon era, and they can continue to do so. And this RBE 1.1 we take into account in the treatment planning system modeling. So we define to the treatment planning system configuration that the RBE of this particular proton beam is 1.1. So everything will be scaled to this proton 1.1. Okay, that is one way of doing it. Another way of doing is which is very uncommon. So the radiation oncologist can prescribe the dose 10% lesser than what they used to prescribe with the photon. And in that case, then we don't take into account of this 1.1 into the treatment planning system. Okay, so there are two ways. So it is up to you how you want to proceed. But in our case, we choose we don't want to disrupt the traditional way of dose prescription. So we follow the same dose prescription method what we follow in case of photon radiation therapy. But this 1.1 is taken into account in the treatment plan.
Thank you so much. The other question is regarding the scatterer material in a scattering foil, and also whether you use the active scanning or passive scanning system in your center.
Right. Oh, in our center, as I said, I think ours is only active scanning. Okay, so we don't use a double scattering or a passive scattering technique. We use only active scanning technique.
But a typical scatterer material would be in a
the primary scatter material in this case, and of course, I think the primary scatter material is going to be, of course, when this proton is going to pass through the multi-layer ionization chamber, which is there in the nozzles to monitor the position of the spot as well as to monitor the accuracy of the dose delivered. Okay, and during these interactions, so there might be a very, very, very small neutron dose which is being generated, but that is going to be very, very minimal, and it's going to be, I would say, that almost negligible. And secondly, I think it is going to interact with the range modulator, range shifter, I think, which we use it to lift the proton energy from 70 MeV to further lower. Okay, so that time, I think it is going to interact with a tissue equivalent material. So therein, I think you may, a very small component of neutron contaminations can be created. And these are almost negligible. And the third component is inside the patient. So when this proton interact with the body tissue of the patient, then it may produce a very, some neutron. But those are negligible. So we do not consider all these components during the time of treatment planning and the delivery process.
Thank you very much. I have a couple of questions related to each other. I combine them together regarding the basics of the proton physics, basically proton interactions. they have asked the major effects of protons traversing the matter, and basically why does Bragg peak happen? What happens in the Bragg peak? If you could just add a sentence regarding that.
As I have shown, I think when proton enter in a medium, the primary interactions related to the dose deposition is through elastic interaction. Okay, and the way how the proton loses energy is again, I think I have shown you one relation which is called the Betro-Bloch equation, and which of course it's a very complicated equation, but primarily what it says is that I think the deposition, the rate of energy deposition or the rate of energy loss per unit track length is dependent on the velocity of the proton wave. So first when it enters, I think it produces excitation and ionization, and which leads to the deposition of the dose. And during these excitations and ionizations, the proton is losing part of its energy. And this loss of energy gradually increases. And as the proton slows down its velocity, then the amount of time the proton spends with the medium is going to increase. So if the amount of time spent by the proton increases, then the rate of ionization increases. That means the energy deposition or the dose is going to increase. And this increase is very dramatic when the proton is about to stop, like when the velocity is about to become zero. So at that point in time, maximum of its energies are released, and that leads to the what we call sudden increase in the dose deposition, which we call as the Bragg peak. I hope I have answered.
Yes, absolutely. Thank you. The other category of questions regarding the practicality of the matters and the clinical aspects. Any comparison? I know it's site specific and it's not so easy to just say like that. But the bottom line is the patient survival, or I would say perhaps more the side effects in the case of protons. But in terms of patient survival, do you have any statistics that you can point to regarding protons versus?
Of course, I think I would say that the data are emerging, and as I think I have mentioned in my earlier talk, that the number of facilities, proton facilities, were very limited, and definitely the number of patients treated. Still today, the number of patients treated with any form of SARS particle is around 2% compared to photon radiation therapy. So we don't have enough data to claim the benefit of proton in all clinical sites. But there are very good evidences in the clinical data which shows that the protons are much superior in terms of both clinical outcome as well as reduction in the toxicity profile for certain clinical sites. Like, of course, the pediatric patient without any say, pediatric patient is the one who benefits the most from proton, and chordoma, chondrosarcoma. So these are some clinical sites where the proton has really shown the tremendous advantage. And of course, there are many other data which are emerging now because the number of proton therapies are increasing. So initially, in fact, the number of clinical sites which was treated with proton therapy was also very limited. So I think it was treated mainly for the ophthalmic tumor, and of course, the clinical data for the ophthalmic tumors are I think very, very promising, very, very promising. Okay. So, and the proton therapy started with the ophthalmic tumor only. So they have a very excellent clinical outcome data from the ophthalmic tumor, and during those double scattering era, the clinical sites treated was limited, say for example, to ophthalmic tumor, some cranial tumor, and the pediatric tumor. But now with the introduction of pencil beam technique in late 2000, I think it was approximately 2000, 2010 or 2013. So from there, I think the clinical sites, the clinical indications also have increased significantly. So let me just share you my slides. So these are the clinical indications, which is approved by different countries. Like in the United States, so these are the clinical indications which are approved for the proton therapy, okay, as a group 1. That means I think you don't have to justify for this tumor. So they can be treated with the proton. And of course, there are another group, I think, wherein you have to justify. And these justifications can be done in many ways. Justifications can be done using a dosimetry comparisons, and that dosimetry comparisons data can be converted into a radiological prediction model. And with that, you can justify. And so this is the site which has been approved in the UK, then the Italy, and similarly the
Thank you so much.
So there are, I think,
sorry to interrupt.
Indications are expanding, okay, and so we expect that more and more clinical outcome results will be emerging, and you can also see from this ongoing phase 3 clinical randomized trial, we are likely to see lots of clinical outcome in the coming years. But at the moment, the data are emerging.
Thank you so much, Dr. Sharma. We have run out of time, basically. There are more questions, really, and it's such a fascinating topic. And thank you so much for your talk. I enjoyed it. I'm sure everybody did. In the interest of time, we unfortunately have to stop here, and I'll hand back to Dr. Chai or Dr. Jin, whoever would like to take over, please. Thank you so much.
Can you unshare, Dayanand, your slides?
Thank you very much, Dr. Amin and Dr. Dayananda, for the very, very informative talk. Yeah, so for the interest of time, I'd like to show you our next webinar.
Yeah.
Yeah.
Yes.
Okay, before we end, just a reminder that our webinar is endorsed by the Australian College of Physical Scientists and Engineers in Medicine. So if you're interested to get a certificate for the CPD point, please register through the link. The link is already posted in the chat room. And the link will be expired within 2 hours after the webinar. And the recording of this webinar will be uploaded to AFOMP website within 2 to 3 days. And our next webinar will be on the 11th February 2021 by Professor Dr. Eva Beza from Australia on the topic an overview of targeted beta and alpha therapies. And our moderator is Dr. Hajime Monzen from Japan. With that, I'd like to thank everyone for your participation today. And I'll pass over to Prof. Arun. You want to say any words?
Okay, yes. Thank you very much, Dr. Dayanand Sharma. Thank you very much, Dr. Amin, for moderating this thing. Again, thanks to my chair, PRC, Dr. Jin, his students, and all the participants for taking interest into this webinar. And almost over 175 participants actually participated in this webinar. It's a good number. And hope that next webinar you will attend in large number and get benefited. AFOMP is trying a lot to disseminate the knowledge. So please take advantage, give us your feedback. Once again, thanking you all. Have a safe time and meet you next time on 11th February. We end up this thing. Thank you very much, each one of you. Thank you.
Thank you.
Thank you.
Thank you. Thank you very much.
Thank you, sir.
Thank you. Bye. Thank you.
Thank you very much.
Thank you, Amin.
Enjoyed it. Thank you very much, Raina.
It was long. It was long. I know. I think it was a big topic. I think it was long. Sorry for taking extra time.
No. It's I would have listened to it all day. No problem. Thank you. That's great.
Thank you.
And thanks to everybody else, and thanks for inviting me. That's great, Prof. Arun. And again, everybody, thank you so much.
Thank you, Dr. Amin. Have a good day, everyone.
Thank you. You too. Bye-bye.
Bye-bye.